of you. We're now going to open it up for questions. We have about 15 minutes, and I'll first turn to the committee to see if there are any questions for any of our panelists. Rich.
Well, one of the themes that's emerged here that, and I'll borrow a phrase that you used, Kathy Kenyon, is a broken culture of healthcare that seems to run through all of the talks we heard this morning. Can you look at the other side of this and talk about ways in which healthcare ought to change or should be changed to address some of these shortcomings you've all identified?
The Institute of Medicine, and I think if you look out there at the policy literature, everybody's talking about person and family-centered care. The professionals who are out there don't know what that means. They don't know how to do it. They actually need research and other help that gives families, that give them models for how to effectively deal with family caregivers, to identify family caregivers in situations where they need to be identified and to pull them in, and then models for how you engage them over time.
So policymakers would probably like some boundaries around the size of the problem that we're dealing with. And we know that the estimates of the populations of recipients or family caregivers are enormously variable. And actually you have, I think, made some suggestions in your presentations that might make it even more variable. Because policymakers would like to know the exposure that they face in terms of governmental approaches, perhaps, to family caregiving and disabilities and the actual care process, including yet even what the ages that they should, because most policies do have some age limits. So can you tell us, how we should approach that? How can we give policymakers the assurances that we understand the magnitude of the problem that they're facing?
I'm not a numbers person. We know that. Family Caregiver Alliance had a very good, but somewhat dated now, comparison of all of the different methods of estimating the numbers of family caregivers. And they range. They range by who's asking the question, what's the definition of family caregiver, all those sorts of things. Any estimate is millions, in the millions of millions. But I think that what we could do is to try to look at stages of caregiving. So not everybody's in the same at the same point. There's something I'm trying to think of called pre-caregiving, where you're not really doing it, but you're worrying about doing it or trying to avoid doing it, where the needs are relatively modest and there's not this strong need for interventions all the way up to the kind of incidents and total care needs that Kathy was talking about or that I experienced. So if you could intervene at a certain point, you could prevent people from moving from a moderately manageable situation into a disaster area. So, I mean, I think it's going to take some more fine tuning and not looking at this population as all of these people needing everything that there is out there. But I don't know how to divide that, but I think that maybe segmenting this in a certain way might be helpful. Kathy, you might have a better idea about this.
Yeah, I think, as Carol pointed out, there's estimates all over the map, but there also is a lot of families need basic information, and that may be actually all they need. So not everybody needs the same level. and not everybody has the same level of intensity as some of the examples that we're talking about here. But I think, you know, it's not one system, it's across a variety of systems that need to pay attention to family caregivers. And I just would like to go back just for a moment and just say that when we look at the integration of family caregivers within systems, I mean, how do we know how many family caregivers are accessing these systems if we don't actually identify them and note that they're present? And that's a big concern. And when you talk about what can healthcare do, just to segue back for just a moment, is that there's not a customer focus, there's not a customer service focus within the healthcare system. The family caregivers are as much a customer as the person that's coming in with them, because they're the ones that are going to be taking care of the situation, be either by assistance or directly in the future. So you're asking a very pertinent question, to be sure. How many families need a range of services, and how many families need an intensive level of service to a basic kind of training and education, is something that we really we haven't put our hands around yet. We can't grapple with this because we simply haven't identified through the process across systems how many family caregivers are asking for assistance in these systems. So you ask an excellent question. I wish I could just say, oh, it's going to be 10 million people, but I'm not so sure that we know the answer to it right now.
Thank you. Thank you.
I actually do have a response to Roger, but it's from my hat as having worked in, I've been the general counsel of a large health system, and I also work in policy. Particular health care organizations are going to prioritize how they approach this based upon how they can most effectively meet their financial needs often. And so as we move to accountable care models, what we're going to do is prioritize family caregivers that keep people out of hospitals. That's not a bad place to begin.
Thank you. Alan?
My thanks to all three of the panelists for a very informative session. I'm going to direct a question to Kathy, and Kathy, let me say ahead of time, if you prefer not to answer, I understand. You're doing a wonderful job of caring for your parents, but I want to know about your own health and your own health care. Is the healthcare system addressing your health and your well-being so that you can maintain your role of being a stabilizing force in your family's life?
My nervous system has at times been absolutely shot. And part of the reason that I asked Mom and Dad to move here is because I was dealing with esophageal spasms and health issues. I've had tachycardia and a whole range of health issues, and I haven't been to a doctor in a year and a half because God knows I don't have time. And so, you know, absolutely.
Thank you. Lisa?
I want to applaud the panel, but I noticed that all three of you mentioned that there is a specific risk associated with dementia care. And I was particularly interested in all three of you in one way or another talking about the need for decision support. And I wondered if you could say more specifically about timing and type of decision support that could be more helpful to families.
I think one of the, I would say one of the positive changes that we've seen over the years in tracking at least families that have initiated durable powers of attorney is that seems to be something that families have caught on that they really need to put together at the very beginnings. I mean, that's not exactly decision support, but it has a huge impact on decision support down the road in terms of executing the documents that allow legally families to make decisions for healthcare or finances. So we have seen, you know, that change over time. We always talk about that the very first time we answer the phone with the family. So what are the mechanisms in place? And secondarily then is advanced directives. What are the things that we can help the family to establish that starts the conversations going about the values and preferences of care for the person that they may be caring for. So we see some of these documents being employed at the very beginning. We need to, continue to talk about that for everybody, durable powers of attorney for everybody. But decision supports, as they move along, decisions are different depending upon where you are in the continuum of care. So it's always about the current, in terms of advising families, about the current situation, but also giving a glimpse and a preview to the future, not overwhelming, but a glimpse of the future kinds of decisions that may emanate out of this particular kind of disease process. And so we spend an awful lot of time educating families about the disease process, and also particularly about dementia, which they may or may not have a firm diagnosis, but it's memory loss, and they come to us with memory loss diagnosis from physicians. So it's really talking about the disease process and what may be their decision-making steps along the way. So it's really almost that pre-decision advising process that we get involved with.
Latson.
Can I just add one thing? I think that the barriers to getting good information that are HIPAA, misunderstandings of HIPAA, and I would encourage this committee to look into that, because you can't make good decisions if you don't have the basic good information that it relies on. And the second thing is that healthcare providers are really reluctant to talk about things like palliative care and hospice early enough in the process, and that helping them to be more comfortable so they can be more comfortable with, so family caregivers can be more comfortable with patients too, that would make a huge difference. It's this last minute discussion, that's really bad for everybody.
Thank you.
In terms of decision support, the first thing is that if someone has Alzheimer's, that should be an immediate trigger for engaging the family. Okay, so, getting it into the electronic records, and is the family caregiver block in the EHR filled in? And do you have in place a system for, there should, the question of whether they've turned on that block or not is an open question. It should be in most EHR systems, even though we don't require it to be in it. So there should be a trigger for family engagement for those patients who have Alzheimer's, because almost by definition, they can't manage the chronic conditions that are coming in the door. I think that the problem that the culture in healthcare has is that the doctors, in fact, don't know how to manage Alzheimer's. There's not a cure for this disease, and the medicines that are out there are just terrible. They make things worse in my experience. The reason you need to identify the Alzheimer's is because the family has to be involved in managing the chronic conditions that people with Alzheimer's have. And you have to pull the families in. Once healthcare understands that the reason you have to identify Alzheimer's is because you pull in the families to then manage the care to keep the people out of hospitals, that's what needs to be prioritized, Roger.
Would you just say one thing about, you mentioned the specialists in Alzheimer's were the ones that didn't have the information you needed? Could you just talk a little bit about?
They want to be able to manage it with medicine.
Oh.
They're not dealing with the family caregiver trying to manage, my parents, they have Alzheimer's, but they're wonderful people. They still are struggling with living a meaningful life. That's what I'm trying to deal with. I need to understand the trajectory of this disease, and they are terrible at managing that. The medicines that are available put my father to sleep. We took my parents off of the medicines because my mom wants Dad not to sleep all the day. She wants to have a companion. The doctors aren't dealing with that existential reality.
Yeah, my question is, I guess for Kathy Kelly, but perhaps for others as well on the panel. And I also wanted to echo the thanks to all of you for participating in this. My question is actually about a challenge that I think we face now and into the future with the increasing ethnic and cultural diversity of our caregiving population. And so as a committee, this is one of the things that we're grappling with. And I wonder from your perspectives, what are the most important considerations in meeting the needs of this increasingly culturally diverse population, older adult population and caregiving population?
Well, there's some obvious challenges, one of which is language, but that's not always present. It's really having basic understanding of, what might be the cultural values and preferences within different ethnic populations, but also understanding that that there might be some conflicts about those roles within, from each generation. There may be conflicts of wanting to adhere to those roles, these particular assumptions about ethnic values and preferences. It's not such a black and white issue. We tend to say, oh, a certain, Hispanic families are all, take care of their own and so on. But when you really dig down, they're dealing with the same kinds of pressures and considerations as everybody is. But I think we need to be mindful of the fact that there's going to be the culture of ethnicity and also the culture of how that, may be different between generations. And that, there's strengths and there's also weaknesses in terms of the assumptions. But it's really important for everyone to have, in terms of training, to have not only training about the sensitivity about the cultures, but training about the respect for the values and preferences within that whole family unit.
I think you have to ask each family, what is it that's important to them in terms of their religion, in terms of their culture, in terms of food, all of those things. And family caregivers will answer differently. We have, the United Hospital Fund, we have a series of family caregiver guides in 4 languages, English, Spanish, Chinese, and Russian. And we've recently experienced an upturn in our Spanish language viewers. They are looking at exactly the same guides as the English language in the same proportion. And in both cases, it's the guide to hospice and palliative care. So you will see things that say, oh, Hispanic families don't want to know about hospice. Well, they're coming to our website to find information which they're not getting anywhere else. So I think we want to approach each family as its own thing with some sensitivity to overall cultural issues.
We have,
Lynn, I think we can take the
unfortunately,
last 2 cards. My boss here to the right, Jill, says we can take the
we
last 2
can.
cards.
Thank you so
and,
much.
And we'll ask our committee members to be
Great.
specific and directed so that we can then move to our next panel.
Great.
So let's say Linda and then Carol.
Excellent. Thank you.
Thank you for your lovely presentations. I'd like you to, if you could, to put on your advice to practitioners and healthcare systems hats, because there are several things that you said that made me think that you might have some suggestions. The first is about HIPAA and privacy issues, which, as you know, practitioners are very nervous about, but also about the issue of multiple people who are identifying as family caregivers, and how does the practitioner sort through that? And then the second issue is something that Ms. Kenyon said about the practitioners were not willing to accept the risks that you were willing to risk. And as a former family caregiver, I understand that very well. But so can you talk a little bit, perhaps even as a general counsel, and as healthcare professionals also, about how you would advise practitioners and systems?
In my statement, I talk about HIPAA. What I'll say is that I'm a HIPAA lawyer. I have colleagues who are HIPAA lawyers. They are also caregivers, and the experience that Carol talks about, we've all had. The difference is that when I get nonsense from from people, I say, that's not true. Can I please speak to the privacy officer? And usually that resolves the issue. But it's very clear that that we need better advice, and I would encourage you to ask the Office for Civil Rights to clarify HIPAA. I think that the multiple caregiver situation, I'm so tired of having people tell either me or my parent, the spouse of whoever's in the hospital, that one of us has to leave. You simply have to deal with multiple caregivers. That's just it. If both of us need to be there in order to help that person, my mother, 65 years, is not going to sit in the waiting room so that I can give an accurate medical history. You just have to deal with it. In terms of the risk tolerance, I cannot tell you how many times I've said, put in the record that the family member disagreed with your advice and we're leaving anyway. Just paper the record and expect to do that. So that would be my advice.
I interviewed Leon Rodriguez, who's the head of OCR, for an interview that was published in Aging Today, and on HIPAA.
That's the Office of Civil Rights.
The Office of Civil Rights. And he couldn't have been clearer. He couldn't have been more commonsensical. He said, we need more education of healthcare providers. And yes, there are real serious issues around privacy, but they tend to be around people losing laptops or taking information about a celebrity. And so the issue is somehow this climate of fear has pervaded the healthcare world, and that it isn't really based on the law. It's based on whatever advice they got 10 years ago when it was introduced. So I think there's an re-education process that needs to happen.
I don't want to blame HIPAA, though. I actually think that HIPAA is used by a culture that wants to control the patients and does not trust family caregivers. And so it's a way, it is an excuse for actually separating families so that they can just control the patient themselves.
Thank you for that. Do we have time for Carol to ask her question?